Hi everyone, this is going to be a very quick video on ethics and medical ethics, and I'm going to be briefly talking about the use of translators in consultations and hospital scenarios as well. Now, if used correctly, translators can be a very important resource to use, and unfortunately in Australia, although we have a wide number and a very large number of translators, they are quite underused by medical professionals. So hopefully this video can give you some exposure onto what translators do and basically what their roles are, as well as the hierarchy of translators that you should be taking into consideration when you do have a patient presenting to you who does not speak English. So before I get started, all of the translators in Australia are registered under an authority called the National Accreditation Authority for Translators and Interpreters. This is abbreviated to NAATI, and there are 3 levels of NAATI speakers or translators that you should be aware of and that you should be using for your consultations if you do get a patient who doesn't speak English. So the levels of NAATI, or National Accreditation Authority of Translators and Interpreters, speakers, I'll just say. Firstly, include what we call level 3 speakers, and these are interpreters that are trained in giving health advice. These are probably the best translators that you can use for any consultation that involves a patient who does not speak English, because these interpreters are specifically trained in giving health advice. They know for their respective languages the medical terms and the proper way of expressing medical sentiment, and maybe if it's bad news that you're breaking to a patient, particular bad news in their language and in a culturally appropriate manner. Now, the thing with level 3 interpreters is that since they are so specialized, they are not as readily available in hospital scenarios, and this is usually pertinent in rural communities, rural and remote communities, where you may be getting a patient who does not speak English. Usually in rural and remote communities, these are Aboriginal and Torres Strait Islander people. So if you do get in the scenario, it's likely that you may not get a level 3 trained NAATI speaker, and that can be quite problematic. So you have to come up with other ideas or consult with lower levels of the hierarchy of speakers to use to allow for efficient communication of health material with this patient. Another key thing that I want to talk about with the use of translators is that some larger hospitals also contain face-to-face translation services, and when these are available, I would highly recommend using them, because the advantage of using face-to-face translation services is that they allow for the ability of various emotions and gestures to be present within language expression, and sometimes these emotions and gestures may be quite relevant to a particular language. So as you can see, a phone consultation is not always effective. Now, the lower level that we get from level 3 translators are level 2 translators, and these are interpreters that are trained, so they have formal training from the accreditation authority, but they do not have, but with no special knowledge, so they're not specifically trained, with no special knowledge in giving health advice. And this is where sometimes the use of interpreters can become quite dangerous. If you don't have an interpreter who is specifically trained in giving health advice, then this can mean that they may mistranslate some information. There may be an aspect of miscommunication, which can reduce the doctor-patient relationship, such that the patient experiences a lack of trust in the doctor. So that can mean that the patient essentially loses the ability to effectively communicate with the patient and vice versa, with the doctor. So as you can see, these people can be quite effective if it's the news that you're delivering is maybe less health-based and less serious, but if the news that you're trying to give out maybe is a part of a diagnosis, a serious diagnosis, then it is recommended that you use a level 3 translator. But once again, these people aren't always available. Finally, level 1 translators are provisional interpreters. So these are people who have been trained, but they're not necessarily as good as other interpreters and translators who you may find higher up in the hierarchy. And these are translators that may be only available in remote and rural areas. So as you can see, sometimes these translators have to be used, and they can prove sometimes a difficulty in translation and may result in difficulties with giving off the right information. So the fourth level that I want to talk about in reference to these translators is what I call wholly untrained translators, or wholly untrained interpreters. And if you're wondering, this is just not even related to medicine in any way. A side note, the difference between an interpreter and a translator is that a translator is responsible for the translation of the written word, so translating written documents, but interpreters are associated with spoken word. So wholly untrained interpreters are people who can include members of the patient's family, translators that may be registered with NAATI but have not received any training, and other doctors and professionals who may be present in your practice that do speak the same language of the patient, but they are not trained in any specific manner. And it is usually not recommended that we use wholly untrained interpreters, usually for the obvious reason that they aren't trained and may not be able to provide proper knowledge to the patient. But in extremely extenuating circumstances where really there are no other resources present, then we may need to use these interpreters. And even when using these interpreters, there is a certain hierarchy that is present. Usually we say that having family members translate for a patient is the last resort, because family members do have the ability to have their own agenda. They may be hiding some information from the patient for their own protection, or they may be uncomfortable sharing some information with that patient. Say, for example, if the condition is related to a personal area of their body, or it's quite serious, they may not be able to be wanting to share that information. So usually we say if a doctor or another person in your practice speaks the same language as the patient and is totally unbiased towards the patient, we usually use that person as the best interpreter, because although they are trained, they are unbiased, they are an unbiased observer, and they can allow for effective interpretation of the information. Usually if they're a doctor, that's the best case scenario, because doctors have specific training in delivering should that be bad news or any type of medical information. So the doctor will be able to allow for that translation of information effectively. That being said, if nothing is available, if no one is speaking the same language, then last resort is family members, and you should pretty much never use any children in translation services. All your people should be above the age of 18 to ensure that they have appropriate education. And usually it's quite traumatizing for children to maybe translate information for their parents. So children under 18, I mean. So it's important that we always use adults and people who are able to understand the medical information properly as a method of translation. So in this video today, I've gone through the 3 levels of NAATI speakers, or speakers who have been accredited by the National Authority for Accreditation of Translators and Interpreters. So we looked at first level 3 translators, which are trained in giving health advice. Level 2 interpreters, which are trained, but they don't have specifically any special knowledge in giving health advice. And then finally, provisional interpreters, which are then ruled off. I should probably denote it by some sort of line, wholly untrained interpreters, which are not part of the NAATI speaker hierarchy, but can include members of the public. Now, a final note that I want to end this video with is the reliance that clinicians have on interpreters. And although I said at the start of the video that interpreters and translators are used at a very low rate in Australia, unfortunately, even though we have a lot of them present, having total reliance on interpreters and translators is not very effective as well. If you get a family presenting to your practice and you immediately go to use an interpreter before trying to work out problems with the patient as best as you can, it can sort of give the message to the family that you don't trust them and you have an over-reliance on interpreters and translators. So that's a very fine line that you have to walk when you want to decide to use an interpreter. But at the same time, it's important that if you don't understand the patient's language, that you don't use speak to the patient yourself throughout the consultation, because essentially that's a virtue ethics infringement, in that if you aren't able to understand the patient's language and you still continue with the consultation, then you're essentially putting the patient's health at risk, since you aren't able to understand that patient's proper medical knowledge and proper medical condition in a coherent and culturally appropriate manner, which means that unfortunately you have to resort to a translator. But in that case, it's better to use a translator than just simply to wing it as such. So this has been a little bit of a different video. It's been an ethics video on translation. I hope you've enjoyed it, and thank you very much for watching.